This conference will now be recorded.
All right, well, thank you everybody for joining us here tonight for our fifth and final session. I know many of you who are on the line right now have been with us all day today, and I can't thank you enough. You guys have been great. You've been engaging and just love everything that's been going on here today. And but for those who you haven't been on, I just want to introduce to you the Lurie Children's team for the Division of Orthopedic Surgery and Sports Medicine. For this session, we will be introducing you to Dr. Cynthia LaBella, and she will be discussing pediatric ankle injuries. But before I do, I would like to talk to you a little bit about the Division of Orthopedic Surgery and Sports Medicine. We are nationally ranked by U.S. News and World Report. We care for more than 30,000 children each year, providing a range of services for children with bone, joint, muscle, ligament, tendon, and nerve disorders, and offer the only pediatric bone health program in Illinois. This is how we are able to recruit the finest specialists in the nation, such as Dr. LaBella. The Knee Injury Prevention Program, also known as KIP, is a neuromuscular training program designed to reduce the risk of ACL injuries among female adolescent athletes. KIP for Coaches is a free online training program to help coaches reduce the risk of ACL tears and lower extremity injuries in their athletes from ages 10 to 21. In KIP training, coaches learn how to lead their athletes through a 10-minute warm-up routine that includes strength training exercises, plyometrics, balance training, agility drills, and active stretching. Our clubfoot program is a comprehensive and multidisciplinary program for clubfoot, a congenital condition that can affect one or both feet in newborns. The concussion program is uniquely qualified to evaluate, manage, and treat concussions in children and adolescents. I would like to remind you that our new Skokie site is up and running. We have over 20 specialties, including orthopedic surgery, sports medicine, and cast care services. Our sports medicine team is there 5 days a week, one of which is Dr. LaBella. Dr. LaBella is the medical director of the Institute for Sports Medicine at Lurie Children's and professor of pediatrics at Northwestern University's Feinberg School of Medicine. After earning her medical degree from Cornell University Medical College in New York and finishing a residency in pediatric at Johns Hopkins in Baltimore, Dr. LaBella completed a sports medicine fellowship at the University of North Carolina at Chapel Hill. She is board certified in both pediatrics and sports medicine and joined Lurie Children's in 2004 to develop a comprehensive program in pediatric sports medicine, encompassing clinical care, research, and community outreach. Dr. LaBella has served as team physician for youth, high school, college, elite, and professional teams. She is currently the head team physician for the USA Rhythmic Gymnastics national team, Salle High School, and Northside Youth Football League in Chicago. Dr. LaBella is the chairperson for American Academy of Pediatrics Council on Sports Medicine and Fitness from 2014 to 2019, and prior to this, she serves for 7 years executive committee as its policy coordinator. In 2020, she was selected to serve on the President's Council for Sports, Fitness, and Nutrition Science Board. Dr. LaBella is an active member of the American College of Sports Medicine, and she contributed as a co-author on several team physician consensus statements. In 2020, she was elected to the board of directors for the American Medical Society for Sports Medicine after serving on a research committee for many years. Dr. LaBella is also the Sports Medical Advisory Committee for Illinois High School Association, U.S. Soccer, and Pop Warner. But I'm sorry, I did a little Ron Burgundy there and I lost my train of thought. I would like to encourage you to ask questions in the chat room, but without further ado, here is Dr. LaBella to talk to you about pediatric knee injuries. Dr. LaBella, here is the screen, and go ahead and take it away.
Thank you so much, Chad, for that nice introduction, and thanks to all of you for joining today, especially if you've been on all the other talks. I've been in clinic and I've been actually listening when I can, and I'm always impressed with our team There's just a wealth of information. So I'm going to wrap it up here today and talk about the evaluating the injured ankle. I think the timing of this is fabulous because kids are now starting sports. Now that we're in phase 4 and sports are allowed under IDPH, we're starting to see kids get more active, which is wonderful. At the same time, that just means that things are going to happen in terms of injuries. So this is a good way to get prepared. Can everybody see my screen?
We can, but why don't you go ahead and put it in presentation mode if you can.
Yeah, how about that?
It is beautiful. Take it away.
And I have all the GoToMeeting stuff on the right side of my screen. Hopefully you guys don't have that showing.
We do not.
Okay, great. I'm going to get rid of that. Okay, good. All right, so the overview for today's talk. This is not. There we go. So first, we're just going to do a quick review of the anatomy around the ankle, so everybody reminds themselves of what all the structures are that are frequently injured and what they're called. We're going to go through some exam techniques that you can do in the office that are not too difficult, and then talk about when to be concerned enough to order x-rays and what type of x-rays. And then we'll talk about the most common injury in sports, which is an ankle sprain, and how to treat it, how to make a decision about returning to play, and some prevention techniques. All right, so here we go with the anatomy. And so I have 3 pictures here. One shows the lateral side of the ankle. So this is your fibula here. Everybody hopefully can see my pointer. 85% of ankle sprains occur on the lateral side of the ankle. And there's 3 ligaments that can be injured. One is in the front, it's called the anterior talofibular ligament, or the ATF. And then we have the calcaneofibular ligament, the CF, and the posterior talofibular ligament, or the PTF. And that's the order in which they're torn, meaning that it's most common, the most commonly torn ligament is the ATF, and then the second most commonly injured is the CF, and the third most common is the PTF. So 85%, as I said, of sprains are on this lateral side, and they're due to an inversion injury to the ankle. And if we look at the bony anatomy down here in the lower right corner, that helps us to understand why there are so many more inversion injuries to the ankle, causing lateral ankle sprains than eversion injuries. So as you can see, the fibula extends a lot further distally along the side of the talus than the tibia does. So there's a stronger bony block on this side, blocking eversion, than there is on the medial side. The other thing is there's a difference in the ligaments. So on the medial side, you have this really big, thick, segmented deltoid ligament, which is very, very strong compared to these thin ligaments on the lateral side. So this ligament resists eversion a lot better than these ligaments resist inversion. So for that reason, sprains to the medial side of the ankle are a whole lot less common. So only represent 5% of sprains to the ankle, or to this deltoid ligament. The rest of the sprains are to what we call the syndesmosis. And so part of that is visualized here. So you've got 2 ligaments, one in the front and one that's not drawn on this picture, but in the back, that connect the distal tibia to the distal fibula, along with a thin membrane called the syndesmosis that goes all the way up the length of the 2 bones and joins them together. And so there's something called a high ankle sprain, which is the term given to when one of those ligaments, or the syndesmosis, is sprained. And generally the difference there is where an inversion injury or an eversion injury that causes a typical ankle sprain, the foot is in plantar flexion. With these syndesmosis sprains, typically the foot is more in a dorsiflexed position when it happens. Nonetheless, they still are far less common than the lateral ankle sprains. But the important distinction and the ability to be able to tell a patient whether they have a lateral ankle sprain, a syndesmosis sprain, or a medial ankle sprain is that lateral ankle sprains heal the fastest. and syndesmosis and medial ankle sprains take a lot longer to heal. So if you're able to identify which ligament is injured, you can give the athlete a better sense of how long it's going to take them to get better. And then the other thing that we have to be aware of in growing athletes who are still skeletally immature is that the growth plate can be injured too. So on this x-ray, it shows where you find the growth plate. And when you're examining someone, you can find the tip of the malleolus either on the lateral side or the medial side. And the growth plate is always about a finger's breadth above that spot. So that can guide you in terms of your exam where to find the growth plate. All right, so I have a video here, and let's keep our fingers crossed that it's going to play. But this is the lateral side of the ankle, and we have some marks here that indicate the key structures to palpate. So this is where the ATF lives, that most commonly sprained ankle or ligament in the ankle. And then the CF lives right here. The PTF is back here. And then I put a line right here where the growth plate lives. And then the very last thing that we always want to make sure we palpate is the base of the fifth metatarsal. And that's because any inversion injury to the ankle also puts stress on this area. And so there's a potential that there could be a fracture there. So you always want to palpate that. So let's make sure this plays. And this just kind of takes you through how we would approach this and palpate those four spots. Can everyone see the video?
Sure can.
Oh, yay. All right. So that's kind of the approach to the lateral ankle. So, and then the medial ankle, there's the growth plate. And the deltoid we sort of described as being this fanned out, multi-segmented ligament that's pretty broad. So it encompasses this whole area. And this kind of shows the technique in palpating the medial aspect of the ankle. So you really want to go all along that whole ligament. Sometimes they're just tender in one part of it. So that's why you want to make sure you hit all those areas. Okay. So then another aspect of the examination when you're evaluating, especially for a sprain, if they're tender on one of those ligaments and you suspect that there's been an injury there, this is a way to tell how injured is that ligament. Is it mildly injured? Is it a stretch injury? Is it a partial tear? Is it a complete tear? So there's something called the anterior drawer test, which checks for the integrity of this ATFL, this most commonly injured ligament in the ankle. And this is the positioning for the hands. You want to cup the heel with your non-dominant hand, and with your dominant hand over the distal lower leg, you're going to attempt to pull that heel forward and put tension across this ligament. So kind of like a drawer, you're pulling forward with this bottom hand, and you're checking for two things: how much laxity you feel compared to the uninjured side. So you're always going to want to be examining the uninjured side first. And you're also checking for a solid endpoint. And so the reason for that is that if there's a partial tear, you might get a little bit of laxity when you do this compared to the other side, but you're still going to have an endpoint because part of that ligament is intact. Whereas if it's completely torn, like this image is showing, you're really not going to feel an endpoint. You're going to feel like you could continue to keep pushing it or pulling it, and it will continue to translate. And again, doing the uninjured side first is super helpful. It gives you a sense of what to expect and something to compare to. And then this is the Taylor tilt test, which tests for the integrity of the calcaneofibular ligament, which lives again on the side of the ankle. And your hands are in a similar position. You've got this hand cupped around the heel, but instead of pulling the heel forward, you're basically recreating the mechanism of the injury by briskly inverting the ankle. And again, you're feeling for translation and an endpoint when you do that exam compared to the uninjured side. So here's how this looks when you're doing it. So that's your anterior drawer test. So you're pulling forward, and that's your Taylor tilt test. All right, so now let's go through a case and we can kind of walk through how you put all the pieces together from your history and your exam to kind of guide an athlete after an injury to the ankle. So this is a 16-year-old basketball athlete. He was going up for a layup, but when he came down, he landed on an opponent's foot and he inverted his ankle. He felt a painful pop at the time of the injury and had immediate swelling. And he limped off the court. He had a little bit trouble putting weight. He was helped by his teammates, but he was able to put some weight on that and walk off the court. But he wasn't able to finish playing the game. So he comes in to see you the next day. He can bear weight, again, but it's quite painful. He's got significant bruising and swelling on his lateral ankle, as you can see in this picture. He's tender along the ATF ligament and the calcaneofibular ligament. He doesn't have any bony tenderness, but when you do his anterior drawer test, it's positive. So he does have some laxity there and some pain. When you do his Taylor tilt test, though, it's negative. It's symmetrical to the other side. So the next question is, do we need to do x-rays on this ankle? And many of you probably are familiar with the Ottawa ankle rules. So we'll kind of walk through and apply them to this case. But the Ottawa ankle rules state that if you have any tenderness at the posterior edge of either of the malleolus, either the lateral or the medial side, so any bony tenderness there, or if you're unable to bear weight immediately after the injury and for 4 steps in the ED or the clinic where you're being evaluated afterwards. All right, so let's talk about this for our patient. He does not have any bony tenderness, so he doesn't meet this criteria. He was able to bear weight immediately, and he can take 4 steps in the clinic. So he does not meet our criteria for getting x-rays according to these Ottawa ankle rules. They were originally studied in adults and found to be 100% sensitive for fracture. And then when they were studied more recently in kids, there's been probably 2 or 3 studies now. And initially the sensitivity was felt to be pretty close to that of adults, close to 100%. But when you specifically pull out the skeletally immature population, so kids under 15, the sensitivity drops a little bit to 80% for fracture. Now, one caveat here is this includes small little avulsion injuries, which would be classified as fractures, but wouldn't necessarily change your treatment because those injuries are typically treated the same way as sprains. So even though these studies are showing that slightly lower percentage for fracture, I think a sensitivity approach is 100% and the same as adults for ruling out the more significant fractures that you would definitely change your treatment for. All right, so for this patient, we decide not to order x-rays. We're pretty confident that this is a sprain. And we know it's an ATFL sprain because that's where he's tender and that's where his anterior drawer test indicates some laxity. So here's how we grade these sprains. So a grade 1 injury, and the illustration here is nice because it shows you what this looks like. Now, this actually is an illustration, unfortunately, of a muscle, but let's pretend that this is a ligament. If you have a stretch injury to this structure, you're going to cause a little bit of microscopic tearing in this area, but the structure itself is intact. You're going to have pain with your anterior drawer test, but no laxity. So that would be called a grade 1 injury to the anterior talofibular ligament. If you have a partial tear in the ligament, a macroscopic partial tear, you're going to get some laxity when you do your anterior drawer test, but you're still going to feel a firm endpoint because you have something there to stop that motion. So this would be a grade 2 or a partial tear. A grade 3 or a complete tear, you would get significant laxity on your anterior drawer test and you would not feel that nice endpoint, as we said. So for our patient, he had some laxity and pain, but he did have an endpoint, so we're putting him in this category of a grade 2. And here's why, we'll talk in a few more slides, why it's important to be able to classify these injuries grade 1, grade 2, or grade 3, just because you can give someone a sense of how long it's going to take them to get better. But initially, no matter what grade of injury you have, the treatment is the same. So the first 48 hours, you're going to want to use, everybody's familiar with the RICE mnemonic, rest, ice, compression, elevation. So now, kind of modern day, we use this term PRICEM. We put a P in front for protection, So that's providing some support for the joint. And then an M at the end for mobilization, because what we know now is that the sooner you can start mobilizing that joint when it's after there's a sprain, the better. So we try to do all of these things right in those first 48 hours. These air stirrups work really well by providing both compression and some protection, because they're provide this rigid surface on the outside and then that nice soft either a memory foam or they kind of fill with air on the inside. We have them ice as often as every hour and leave the ice on for 10 to 15 minutes at a time. No heat in the first 48 hours because heat can make the swelling worse. We have them elevated as much as possible. Gravity really works against you in these situations, and you really want that ankle elevated above your heart as much as you can. And then the mobilization is super important. And in the next slide, I'll kind of give you some background about what kind of exercises we recommend during those first few days. But right away for a sprain, I usually get people started on some ibuprofen. And here's why. There's been some research that shows that it can actually shorten the recovery time and return to play time by up to 2 days. And the reason for this is thought to be not so much the anti-inflammatory properties of the NSAID, but the analgesic properties, because they limit the amount, or they reduce the amount of pain that the athlete is having. That means the athlete can actually proceed through some of these exercises in a little bit more quickly and get back to play. So the dose I usually recommend, especially for a teenage athlete, is the prescription strength dose for ibuprofen, which is 600 milligrams 3 times a day. So here are those rehab exercises that we give during the first 48 hours. For sure, we have them doing simple range of motion, which is you can tell them to write the alphabet in the air with their big toe and do that a few times a day. It's really important to stretch the calf muscle. So we have them do this really easy stretch with the towel and just pull gently till they feel a stretch in the calf, but not to the point where they feel any pain in the ankle. And then here's a really simple isometric strengthening exercise that they can do that usually doesn't hurt at all in the first few days or the first week after the injury, but keeps those everters, those ankle everters, nice and strong. So they put a pillow against a wall and then put the ankle and the foot right up against the pillow. So they're not moving the ankle at all. They're just pushing against through the outside of their foot against that pillow. And we call it isometric because the joint's not moving at all, but the muscle's contracting. All ankle sprains really need some type of rehabilitation for optimal healing. And the reason is because they, anytime you stretch a ligament and you have some swelling in that joint, it distends the capsule, you get some stiffness, you get some disruption of the proprioceptive nerve fibers around that joint. And so it alters the way the joint moves, the way it responds to perturbations when you're running, when you're jumping. So retraining all of those functions is super important and can facilitate return to function. Not everyone needs formal physical therapy. So someone who's maybe not necessarily a competitive athlete, maybe is not involved in any sports, could do just fine with a home exercise program, or maybe somebody has an insurance plan that doesn't cover physical therapy. There are plenty of really nice resources out there on the web. I just listed one here. This is from the American Academy of Pediatrics on their healthychildren.org website. They have a really nice illustrated home exercise program for ankle sprains that you can print out and hand to the patient. But I think for higher level athletes, especially those who need some supervision, and I feel like for a lot of these athletes, they need to be held back a little bit, right? Because they really want to get out there maybe sooner than they're ready. And so if they can meet with a physical therapist a couple times a week, that therapist can guide return to play and really be checking them frequently and do some functional evaluations and give them that guidance. And it's important to remember, and one of the reasons rehabilitation is so important, as I said, is to retrain all those functions that the joint does. But a lot of times, if someone doesn't have the right amount of rehabilitation, they're going to have persistent pain after that ankle sprain. So if someone comes to see you 6 weeks after they sprained their ankle and they say, you know, I rested it, I iced it, I elevated it, I really gave it a break for a while, a couple weeks, and then I went back to play and it's still hurting. Well, if they never had any rehab, then that's the most common reason for persistent pain after an ankle sprain. So it's important to keep that in mind. A lot of people will feel like, oh, maybe there's a different injury here. Maybe we missed a fracture, or we missed a different entity going on. But the first thing to think about is, did they do appropriate rehab? So in terms of when somebody is ready to go back to play, here are the criteria we use. So first of all, they have to have full range of motion of that joint, and that's easy to assess. You can compare it to the uninjured side and make sure that their active range of motion is full in all directions. Their strength should be at least 85% of the uninjured side in all planes of motion. And then here's some things you can do in the clinic to test if they can do these sport-specific type movements without pain or instability. So running and cutting, things that they have to do on a court or on the field, and you can have them run in a figure of 8 to mimic that in your clinic. You can test their balance and their proprioception by having them balance on the affected leg and making sure they can do that for at least 10 seconds. And then check their ability to kind of jump and land by having them do 10 single leg hops and make sure they can do all of that without pain or instability. If they need a brace or some ankle tape to do all of this without any pain, that's fine. These things, the brace and the tape, can actually facilitate return to play by stabilizing the ankle and providing that support and eliminating the pain to allow them to get through these functional activities. So that's where those come in handy. And here's what I was mentioning about being able to give them a sense of how long it's going to take to get back. So being able to grade their sprain is super helpful, because for someone who has a grade 1 sprain, you can say, you know what, probably in 1 to 2 weeks, average of 9 days, you're going to be back on the court, you're going to be back on the field. But if it's a grade 2 sprain, it's going to be a little longer, 2 to 3 weeks. Grade 3 sprains take the longest, closer to 4 weeks. And if it's not a lateral ankle sprain, if it's a medial ankle sprain or a syndesmosis sprain, those usually take 6 to 8 weeks. So being able to do all these tests, and these are all things you can do in your clinic. You don't need to order an x-ray. You can do all these physical exam tests and be able to give them prognosis. So it's really nice once you get comfortable with this physical exam. So let's talk a little bit about prevention, just a little bit of information about these ankle braces and taping of ankles. So this is a photo of an athletic trainer doing the standard ankle sprain taping for someone. There have been studies that looked at both taping and different types of these semi-rigid braces that are designed to play sports in. And what these studies have found consistently is that all of these things do reduce the risk of re-injury. Not only that, but there have been some larger studies in high school football and high school basketball athletes that show that even if you've never sprained your ankle, taping and bracing can actually reduce your risk of an ankle sprain, of a first-time ankle sprain. So these things do work. They can prevent primary and recurrent injury. In terms of which brand or whether they should pick taping or bracing, it's really patient preference. I let them know, look, there's some pros and cons. You know, with the tape, you need an athletic trainer present or coach, somebody that knows how to do this well. And over time, the tape can get kind of expensive if you're doing it every single time, whereas you pay the upfront cost for the brace. And the nice thing about it, the brace, is you can put it on and off yourself. You know, at halftime, sometimes these things tighten up. You can tighten it up yourself halfway through the game or practice. So you're a little more self-sufficient with these braces. But they do help with prevention. And then Chad introduced our knee injury prevention program at the beginning of the talk. Even though it's called KIP and it's called knee injury prevention, our study that I'll tell you a little bit about that we did back in 2006, we actually looked at ankle sprains as well. This was a randomized, large controlled study that we did with Chicago Public Schools. We had almost 1,500 basketball and soccer players at the high school level. They were all female athletes. We divided them up randomly by team, by school, into an intervention group that did the KIP exercises that we called neuromuscular training. And they did all this before practices, and the control group just did their usual warm-up. We tracked injuries and exposures for all the athletes over the course of a season. And then we did some analysis and found that the teams that did the warm-up had significantly lower rates of not only ACL injuries and knee sprains, but also the KIP warm-up reduced ankle sprains by up to 62%. And there have been lots of other studies similar to ours looking at these neuromuscular training programs that have showed similar results, that not only are we reducing knee sprains and ACL injuries, but they do have some protection for ankle sprains as well. And then the key components of these programs really are strengthening for not just around the ankle or around the knee, but the whole core. So the trunk, the hips, and the legs. There's a series of repetitive jumping exercises that train those muscles to be more powerful, but also repetitive jumping helps the athletes learn how to stabilize those joints when they're doing those motions. And the key part of these programs are feedback to the athlete, which they get from our KIP instructors and get from their coaches once their coaches learn how to do this on proper form, and how to not only execute these exercises with proper form, but how to execute athletic maneuvers on the field or on the court with their knee and their ankle in a safe position. All right, so I kind of breezed through that pretty quickly, and we just used a real common injury, but I am happy to take questions about anything I presented, anything I didn't present, any questions you have about the ankle or our KIP program.
That was me.
Or anything else.
Yeah, so Dr. LaBella, this has been great. Thank you so much for going through those slides. I know I've learned a lot. And, you know, one thing you brought up earlier was we're physical therapists and PTs, and we have been very fortunate to have a whole bunch of PTs and trainers with us all day today, including right now. And we've had a few questions come in, and one of them is from Melissa, and she says, what are your suggestions for PTs who have less access to devices such as air stirrup at all if patients are presenting diagnostically with a clear ankle sprain without concern for fracture?
So what to use if you can't have an air stirrup is, or can't find an air stirrup, is what I'm hearing that question to be.
Yes.
Yeah, okay. So yeah, I mean, those aren't always readily available. I think that if you can use a, even just an ACE wrap can provide some compression for sure. And a lot of these things you can find even at Walgreens or now on Amazon. You can certainly order. If the family has limited resources, that's understandable. I think an ACE wrap would be just fine for that situation. And if they're trying to get back to a sport and they need a specialized brace for that, again, maybe working with their coach to see if possibility of being able to tape their ankle would be another choice. Hopefully that answered your question. I'm not sure if there was a second part to that question.
And I would say, given the only 12 people on the line, if you want to unmute yourself and ask a question, you're welcome to do that. I see, Gian, you have a question. Would you like to go ahead and unmute yourself and ask the question? Okay, so she writes, Gian is from Athletico, and she said, great points about ankle bracing, as even prophylactically they can be beneficial in heavy cutting sports. At least anecdotally, have you seen discrepancies between sprains or natural surfaces versus turf?
Okay. So yeah, there have been a few studies looking at more so looking at knee injuries on natural versus turf. I think what we've seen now is, you know, the older turf used to cause more problems, right? So it was a lot harder. There wasn't as much give, and it didn't really mimic what it's like on grass. But the newer turf designs, we're not seeing the injury risk as high as what we were seeing with the old turf. And in terms of return to play, there's no real difference. We don't make any accommodations based on whether they're returning to a natural surface or a turf. I mean, one thing about natural surfaces too is they're not all created equal either. Depending on what field you're on, it could be really well maintained, and some have a lot of divots and holes, and those can be even more risky. Turf nowadays, I feel like turf is a better bet because it tends to be well maintained and consistent all the way through. So yeah.
Mm-hmm. Yeah, we were talking with Dr. Patel about that this morning. That was a similar question was brought up, and he said something very similar. So it's it's turf has come a long way. It's when it was first introduced in the 70s. So another question in from Deanna, by the way, you've been great at asking questions today, so thank you for your engagement. You touched on rigid taping. Do you have any thoughts on the benefit of kinesotaping? I have not had the opportunity to do so. I think prophylactically with kiddos, but I have used it myself during treatment after sprains, at least improve. Geez, it's a word I don't know.
Do you want me to just talk on the mic?
Yeah, that would be great. Thank you.
First of all, thank you, Dr. LaBella. So yeah, I'm just curious about your opinion on the use of kinesiotape. Because I've definitely used that on some of my kiddos after injuries. I don't usually get to see these kiddos before they get injured, but just kind of what your thoughts were on the use of at least a less rigid taping.
Well, there's no data on that being able to prevent recurrent sprains. That being said, I feel like there's definitely value with kinesiotaping for many folks in terms of pain management. So I feel like we've used it a lot with more of the overuse type injuries. You know, if there's a muscle strain or a tendonitis, and we really want to help manage that, manage the pain or give them some proprioceptive feedback. But as far as replacing the rigid tape in providing some stability, it's not going to replace that. Now, maybe you could consider kinesiotape and then rigid tape over top if you want the benefit of both. But I wouldn't say that it could replace the rigid taping, or maybe put the kinesiotape on and then put your brace, right? Your semi-rigid brace over top. Is that your question? Did that kind of answer your question?
Yeah, I was just curious about your thoughts. I know I've definitely seen it improve proprioception for sure following ankle sprains. And I'll tend to use it a lot that way, and then for things like swelling reduction too. But yeah, I've definitely put it underneath braces. I find that works well.
Oh, I'm glad you brought up swelling. I'll just throw this in there. I meant to say on the criteria for return to play list, I meant to point out that resolution of the swelling is not on that list. So oftentimes the swelling is the last thing to go away. You know, they're pain-free, they're doing all their stuff, they have full strength, but they still a little bit swollen, and sometimes parents are concerned about that and hesitate to send their child back. But I reassure them, you know, swelling can take months to go back to normal, and we don't let that hold people up from going back. So that's not a criterion. That being said, that's another value of getting into PT right away. I just feel like with all of the things you guys do with the mobilization and some of the soft tissue work, can really get a hold of that swelling and reduce it right away and get it resolved more quickly than someone who doesn't do PT.
Dr. Bella, Gian writes, what are your thoughts on blood flow restriction training following ankle sprains?
So that's like the hot topic these days, the blood flow restriction. So one of the things about those studies is none of them have been done in kids, so I can't really comment on whether it would be useful in someone who's still growing. But I know there's been some promising studies looking at it, especially after like ACL rehab and after after ACL surgery and some of that rehab, and being able to promote strength gains. But I would hesitate to use it on kids at this point just because it hasn't been researched in that population.
Okay, thank you. You know, one of the things I wanted to bring up this evening is our immediate care that we have in Lincoln Park and in Northbrook. Sports are back for very, minimally, but they are back, and most of the kids are playing their sports in the evening or on the weekends, where our pediatricians are probably closed at that time. So we offer immediate care service on off hours. So for instance, on Monday through Friday, we're open from 4 to 10, and Saturdays, Sundays, and holidays, we're there from noon to 6. And I bring this up as, like I said, with sports being back, we do have on-site x-ray there, and with access into our sports medicine team. And I wanted to know, Dr. LaBella, if you wanted to add any thoughts into our immediate care and how you guys correlate together.
Oh yeah, thanks for mentioning that, because we love it. We work seamlessly with immediate care. Our clinics aren't here 24/7, but they offer being seen, and you can get an x-ray right away. It's in our system. And once you're seen in immediate care, it really facilitates getting a follow-up appointment in our sports clinic. So say it's a Friday night, they get seen in immediate care, they could potentially see one of us Monday, Tuesday of the next week very quickly. And then we have immediate access to their x-rays, and they have peace of mind right away, especially if the family is concerned they might have a fracture. If they get the x-ray right away, they get that answer. And if the answer is no fracture, they can feel reassured and feel better about waiting through the weekend, doing all those things that we talked about: rest, ice, elevation, mobilization, and then see us on Monday or Tuesday.
That's excellent.
And if
Thank
you
you.
ever have trouble getting somebody in, I'll just add this. I think, Chad,
Give me a call.
You're welcome to distribute, right. You're welcome to distribute my cell phone. I welcome calls. It's fine to call me and say, hey, I have someone here that I really think needs to be seen, or what should they do in the meantime? When are you in clinic? Can we get them in? Just, I'm always here to answer those questions. So.
That's great. Yeah, and also call your liaison, whether it's me in the north and northwest, Julie in the west, and Paula in the city in the south. We're here to help you, and we can contact the sports medicine department. That's a great segue into our Lurie MD, which is the last thing I want to bring up tonight, is that we have a dedicated physician-to-physician line, dedicated physician line called Lurie MD for you to call a specialist for questions. And that phone number is 1-855-LURIE-MD or 855-587-4363. And this will help you get dedicated access through Kids Doc will triage it and put you right into our sports medicine or orthopedic surgery department. So I encourage you to use that line. But Dr. LaBella, she can be contacted at 312-227-6190 or see LaBella at LurieChildrens.org. Or if you're able to, Rapid Connect or Epic in-basket message. And Dr. LaBella sees her patients in our new Skokie facility, Lincoln Park, and our Northbrook facility. But with that, I think we'll close out our session. Dr. LaBella, would you like to add anything?
No, this has been wonderful, Chad. Thank you for running this, and I'm glad that people were able to join. And again, reach out with any questions, and we look forward to seeing your patients.
Sounds great. If I could ask you to hold on the line, stay on the line for a minute after recording ends, we'd like to ask you a couple questions. Thank you, everybody, for joining us.